panel for being very gentle with me.
So we're live again. I think we're right live for the next session. So it's welcome to session 2 of day 2 of Rhythm Interventions Online 2023. I'm still Julian Chun, and I'm joined by, again, Duraj, Claire, and Vivek. And as always, we're live, so please submit your questions for the panel and our case operator. And now in this session, the focus is a little different. It is AF ablation with PFA. And now maybe Vivek will be more happy in combination with high density 3D mapping. So let's jump on into the case and without any further delay, move to Spain, to Joaquin Oscar Asensi at the University Hospital La Fe in Valencia. We can see you, Joaquin. Can you hear us and see us? We don't hear you at this point in time. We see you in a nicely great team. Lab looks very clean. So apparently we still work on. Yeah, we work a little bit on the sound, but I'm sure we will be back in a minute. And therefore, maybe it is a good, let's say, bridge to keep up our discussion about the high density mapping information and what we may learn from this. Substrate homogenization, is it the way to go? Ablation, and there's of course also interesting publications which we have been discussing recently. So Claire, would you ablate an area of low voltage diseased areas in the left atrium prospectively?
So I think you maybe had some sound for an instant. Okay, I'm going to continue answering your question for the moment. I think that
if we have the connection to Spain, then we will move to Spain and then continue, keep the question and discuss for later on discussion.
Okay, I'll talk for the moment. But if
Joaquin, can you hear us? So probably again, okay. So now, Claire, we have still some seconds to continue. Perfect.
I'll continue talking for the moment, and if Spain arrives, then you can cut to Spain. So I think if there's a couple of issues. So if you have a macroentrant tachycardia and you're trying to terminate that and you need to find the isthmus to ablate, then I think that your goal should be to do the minimum amount of ablation possible to achieve your goal. So then I think that high density mapping is really useful then in showing you, as we've said, like where those critical areas are. Now, if you're ablating persistent AF, then you may be sort of going on a more speculative course where you're not just trying to kind of ablate a critical isthmus, but you're trying to, create some substrate ablation that you believe might, help the patient stay in normal rhythm. And obviously, there's kind of less robust evidence for that. I think if you see areas which you feel are, sort of low voltage fractionated, then it's worthwhile ablating them. But I think that you don't want to kind of create kind of areas of scar kind of randomly across the anterior wall, because I think in the end that will be pro-arrhythmic and won't necessarily help. So for example, if there's an area close to where you've done your PV isolation that looks diseased, then I think that's kind of reasonable to ablate, and then draw a line between that and connect it to your where you've ablated around the PVs. But I wouldn't kind of speculatively kind of be ablating areas, because I think that basically will cause more problems than it will solve.
Okay, so we got the signal that the case is now ready in Spain, and then we move over to Valencia. Hola.
Hello.
España.
Hola. Hello from Valencia, from Spain. Well, We are happy to share with you this new case in this Congress. This is a lady of 56 years old. She has a persistent atrial fibrillation. He has come to our hospital in sinusal rhythm. The patient is received conventional treatment with flecainide and beta blockers. She's anticoagulated with dabigatran, and the patient has several recurrences of atrial arrhythmias. Then we are going to perform this ablation, this atrial fibrillation ablation. Then our workflow with this kind of procedures always is to perform these ablations in combination with the ultra high density mapping, in this case with rhythmia mapping. We have performed several cases using this combination, and for persistent patients, we think that is important because it allows us to reflect which is the quality of the tissue and to identify the presence of low voltage areas that in some cases can give us or can drive our procedure in order to perform ancillary ablation beyond the pulmonary vein isolation. In this case, this lady is relatively young, then probably we are only to perform the pulmonary vein isolation using the FARAPulse technology. Then firstly, we have introduced a coronary sinus catheter, and we are going to perform the transeptal puncture using the FARA sheath in combination with a radiofrequency needle directly, just using the fluoroscopy as a reference. Okay. We can move on with the procedure, please. I would like to highlight that we have had some problems with the arrhythmia. For this case, we have problems with one part in the back of the patient. Then probably we will not be able to see the FARAPulse catheter in the system. Then this is a suboptimal procedure. I would like to apologize for the inconveniences for the audience. Then the use of this transeptal needle, the radiofrequency transeptal needle, have us to perform this punction. Okay. We have positioned the sheath into the fossa, the ovalis fossa. Then we're going to show the radiofrequency needle, please. Yes, we have passed to the other side. The pressure reflected by the needle is good. Then we are going to inject a little amount of contrast.
So you had pressure control connected to your needle, or?
Yes, we have. I have pressure control in the needle. Yes, we are in the left atrium. Then we are going to push all the system towards the left atrium. We always connect the needle to the, we always have pressure control of the tip of the needle in order, to be more safe during the procedure. We don't use the intravascular echocardiography, then we don't use neither another kind of echography guidance. Then we rely only in the pressure measurements and in the fluoroscopy.
Yeah, I think you made it look very easy. It was very elegant, just jumping in, having the nice movement immediately. But I think it requires some experience to do it this way. Maybe there's comment from Duraj on this.
Thanks, Julian. Hi, Dr. Sanjay. This is Dhiraj from Liverpool. I was very impressed to see your transeptal approach using the radiofrequency needle directly through the Farad drive. Just wanted to ask you, do you have any form of imaging? I know you obviously don't have a transesophageal echo probe, or we would have seen it, and I don't see an ICE probe either. So that is extremely impressive to do this with just pressure monitoring. Because one of the concerns people have with radiofrequency needles is that they can create a hole anywhere. So if you're not 100% sure where you are, it can be non-forgiving. So if you can just take us through that approach as to, do you have any such concerns while using a radiofrequency needle?
Well, using this kind of needles, we are starting to having experience with this kind of needle. We have previously performed several cases using conventional needles, and then I think that what this needle offers to us is the possibility to perform a more controlled transeptal punction, avoiding some kind of jumps that sometimes happens using conventional needles. These movements are avoided using the radiofrequency needles. Then another important thing, I think, is to have a very control of the pressure of the tip of the needle in order to, well, to increase the safety of the procedure. Then I think the main advantage at the end of these needles is to avoid the jumping during the transeptal puncture that sometimes happens with conventional transeptal needles. This is our personal view.
Thank you.
Hi, this is Claire from Cambridge. I mean, I would say that if you have both the pressure on the needle and you have contrast, then you shouldn't ever be in a position where you're putting the sheath into somewhere where you don't know. Like the needle might possibly go somewhere, but then it should never be followed by the sheath, because you'll always check through two different methods where you are before you put the sheath over.
Yes, well, so, okay. Vamos a aspirar.
So wonderful. You now brought over your sheath, and it is a pretty large sheath. So you do now you see aspirating a couple of times. And maybe why don't you tell us, and what are your next steps? What are you planning to do with regards to mapping, and later on, what kind? How do you assess PVs, etc.? Just
no. Okay, the problem is, well, we are having had more problems with the electroanatomical mapping system. We thought that we were able to at least map the left atrium, but finally we will not be able to neither the mapping of the left atrium and nor to identify the Farapulse catheter into the mapping system. Then we should change the procedure using another workflow, just relying on the auriculography or the venography of the pulmonary vein. Then please, we are going to obtain a multi-purpose catheter in order to identify the pulmonary veins. Then, very sorry for the inconvenience, but well, the system has just broken.
This is a true life case, of course. This can happen. We fully understand. Don't worry. Don't worry. We all have been in similar situations.
Yes. Well, when we use the Orion, I know that. Sorry, Tom. Yes?
No, go ahead. You go ahead. You just go ahead. What you wanted to say.
No, what I was commenting that there is a, well, it can be a problem to use a diagnostic catheter using this Faro drive catheter. We are very, we perform very safely the exchanges of the catheters inside the Faro drive sheath. I know that it's possible to introduce bubbles or to introduce some kind of air into the system. Then for us, it's very important to perform all the exchange of the catheters, interrupting the flushing of the sheath, aspiring the bubbles, and then in order to avoid this air introduction into the system. I think from the beginning, we started using this combination, Farapulse with rhythmia mapping of the left atrium. Probably, I remember that we have had only one patient with one TIA 5 days after the procedure. Then I think in our series of close to 300 patients treated with this system using in combination Farapulse and rhythmia mapping system, we have very few cases, or just one case of cerebral emboli that happens in a patient 5 days after the procedure. The patients recover completely 1 hour after the procedure. Then I think this combination is quite safe and can give you some clues, important clues, in order to increase the success of the procedure, especially in patients with persistent atrial fibrillation.
So just for our general audience again, your strategy would be to use a single transeptal approach. You use the Farah drive sheath in order to create your map with the Orion. I assume you were mentioning this, and then exchange it again. But you take that good care of constantly flushing, etc., aspiration in order to avoid any potential air embolism. I have to admit, in my personal experience, I did run into, within my first 25 cases, into air embolisms because I was maybe too fast at a certain point in time. So therefore, my personal approach is to avoid exchanges whenever possible. But apparently this can be done, at least safely done, if you take very, very good care. Vivek, you want to jump on this?
Yeah, sorry, I know this is a mundane topic, but I think it's so critical. And I just really want to emphasize Joaquin's point, which is that it's not just about flushing, because the problem with just flushing is that as you advance, particularly, for example, the pentaspline catheter, which has an open, so as you push it across the septum, the center of it is open and air can get entrained at that point. So if you keep flushing as you introduce, all you're going to do is push air in and flush that air into the system. So what Joaquin said, which I think is absolutely critical, is that he interrupts the flushing, he pushes it in, then he aspirates. So he takes out any air that may have been entrained into the system, and then only does he start the flushing again and introduce the catheter. I think that's really, again, I appreciate it's a mundane point, but it's a really critical point.
Yeah, this is a very important comment. Thank you.
Okay, we are going to move the coronary sinus catheter. Abrimiento por si acaso. Usually when, in this moment, we select the cases in which we use the rhythmia system. For paroxysmal atrial fibrillation patients, what we do is to perform a single shot procedure, just using the Farah pulse catheter and performing a left auriculography. We move the coronary sinus catheter to the right ventricle in order to pace rapidly the right ventricle, and then we perform the auriculography. Please, can you pace the right ventricle? We are in the left inferior pulmonary vein. Okay, okay, stop. Once again, please. We are in the left superior pulmonary vein. Very nice view, okay. We are going to move to the right pulmonary veins. Then we are going to convert this case in a single shot procedure. Then please, can you pace again? Lecta. Left superior, okay. Now we are going to identify, this is the right inferior pulmonary vein. Please, can you pace one again? All right. Okay. Now we are going to introduce the Farah wave catheter. Well, this is not what we do when we perform a single shot procedure. Our workflow is to use a conventional sheath, and then through this conventional sheath to perform a left auriculography pacing the right ventricle. Then after this, after the pulmonary veins identification during this left auriculography, after this step, then we move with the procedure. We perform the exchange of the sheath, we introduce the Farah drive sheath, and then we proceed with the ablation. And then I think one important observations we have obtained by doing maps in more or less 200 patients with using the Orion catheter is to identify which are the weakness of the system. One of the main weakness of the system is that especially when you use the biggest catheter into the flower configuration, is the possibility to ablate a lot in the posterior wall of the left atrium. We have observed in some patients undesired posterior wall isolation using this catheter. Then this observation has made us to move the catheter really anteriorly in order to avoid this extra ablation in the posterior wall of the left atrium. This is the first observation. And the second observation is that in some patients, the anterior carina, especially between the right pulmonary veins, is not completely covered by the ablation. And then, since the first 100 patients, we are applying at least two extra applications in the anterior carina, in the right pulmonary veins, and also in the left pulmonary veins. We observe this lower than desired ablation of the carina more or less in 20% of patients, especially in the right pulmonary veins. Then our workflow perform this single shot device, the single shot procedure is to perform a conventional 8 shots in each pulmonary vein and then to perform extra applications in the carina. Retira. Fentanés no, solo atropina. Retira, me pone una ras. Then we are going to introduce the far-wave catheter. After the introduction of the catheter, we always aspire the sheath in order to remove all the bubbles. And then we are going to flush the sheath. Okay. Before the first application, we always give to the patients, push the guy. We always give to the patients 1 milligram of atropine in order to avoiding the vagal responses during the applications. Then we are in the left superior pulmonary vein. Please remove slightly the guide wire. It's too advanced. Can you pull back the guide wire slightly more? Okay. Well, this is a good point to start the ablation. Then, if you want, this is a vagal response. Can you pace, please? This is a very important vagal response. Can you pace, please? Okay, we are pacing. Okay, okay. No, espera. Yes, I think that the patient has recovered the rhythm. Can you interrupt? Have we? This is despite that we have give to the patients atropine. Okay. Yes, the patient has recovered the rhythm. I think that we can interrupt the pacing. Well, as you can observe, the pulmonary vein has been isolated with the first shot. Then I think we can give the second shot to the patient. Can you pace? Probably we can pace slowly, Pedro. We are going to move the catheter. This is the conventional workflow recommended using Farapulse. I think we can interrupt. Can you apply? When we apply in the left pulmonary veins, we always apply a counterclockwise torque. This posterior wall orientation of the catheter. The patient has entered into atrial fibrillation during the applications. And now she's again in sinusal rhythm. Well, this is the flower counterclockwise. Please, Maritere, can you apply? Okay. Second shot. Okay. Maritere, can you apply? ¿Queda uno? Okay. Application. Then usually from the left superior pulmonary vein, what we are going to do in the flower configuration is to deflect the sieve in order to cover the carina since the left superior pulmonary vein, and to perform a counterclockwise rotation in order to orientate the Farapulse catheter in the flower configuration towards the left anterior carina. Maritere, can you apply? Yes, 2 shots in order to cover this area. We have performed a lot of maps after this kind of applications, and the coverage. Then we are going to move to the left inferior. Can you pull back?
Sometimes losing the connection.
Vale, a ver, saca.
All right.
Retira, retira. We are going to move to the left inferior. Okay. Saca, saca ahí. Retira. ¿Qué? Sigue. Retira. Chica, saca. Retira.
We are
Saca.
experiencing some issues, some connection issues when applying.
Retira.
So if you lose the image from us, it's because of that, because of the application.
Saca. Retira. Saca. Retira. No, esto es otra. ¿Esta cuál es? Espera. Saca, a ver. Probablemente esta sea una. A ver. Retira. Retira y saca. Ok. I don't know. No, no es. ¿Ves? Saca. Retira. Saca. Retira. Retira. Saca. Ok. Vamos a mover a las derechas.
So yeah, we know sometimes it is
No,
pretty
saca, saca,
difficult.
saca,
It can be
Guille.
also challenging
Saca, Guille.
to cannulate different vein positions. This is what we all know, and we have not been commenting so far on the tip of the guide wire yet.
Yeah. Yeah.
This is one of the key learnings also from the manifest, switching, I guess, from the straight, and we have this J-type guide wire here. Maybe maybe Vivek, you briefly comment on this from your experience.
Yeah, I mean, I think the J type is certainly better. So I guess a few comments. One, whether it's J or straight, when the wire comes out of the catheter, you really want to make sure that you come out a little bit slowly, let's say, just because, you know, if you're up against the tissue and you push the wire out, you could perforate something. So that's a sort of a minor comment. The second thing is, you know, it is challenging sometimes, particularly for inferior veins, when you have the catheter at the tip, and sometimes you can't deflect well enough and easily wire the vein. Sometimes what's useful in those situations to pull the catheter way back into the sheath and just use the wire to engage the vein and then track the catheter over. That can also be helpful. And then, but I think that, and then the final point I'll say is this, which is what I think you were alluding to, Julian, which is one of the learnings was with the straight tip guide wire, which is what was initially used in our studies. there was a tendency for the wire distally to be traumatic to the distal sort of alveoli, and that would cause some degree of pulmonary hemorrhage. Karsneven has a very nice manuscript in Cirque, where they looked at their initial experience of 30 or so cases where they did routine bronchoscopy in every patient, and they saw these very distal distal bleeding. And then when they switched to the J-tip, again, not randomized, but still nice study, when they switched to the J-tip and then bronch everybody, they didn't see that. So I think that using either a J-tip or some sort of wire that's distally atraumatic, I think is clearly beneficial.
Yeah, thanks for this important comments and thoughts. What we sometimes do, or we always do whenever it's possible, we may change also the angulation in order to have a second, let's say, perspective, anterior, posterior, etc., which I think is also a little helpful if you use fluoroscopy to guide. But I think, Joaquin, you moved on.
Yes, we have isolated the left inferior pulmonary vein. Then we are moving to the right pulmonary veins. I hope that we are close to finish the procedure. Yes, can you? Okay. We are on the left. Yes. Saca. Yeah. Now. Saca vía. Saca más. Ahí. Vale. We are in the right superior pulmonary vein. We usually, from the left inferior, we move to the right inferior, but in some cases, the sheath of the catheter moves to the superior pulmonary vein, then we keep this position in order to proceed with the ablation. In this case, we are in the right superior pulmonary vein. It's quite common to have at least one spline into the pulmonary veins during the movement, especially because during the right pulmonary veins application, you induce diaphragmatic contractions, then it's very easy to observe the introduction, at least of one spline into the right pulmonary vein. Please. Because of the negative pressure that the diaphragmatic contractions induce.
True.
Make you perform several repositionings in the right pulmonary vein, especially in the right superior pulmonary vein. In fact, in our experience, in which we apply more applications in comparison to the other pulmonary veins. I don't know if it's the experience of the...
Are you saying you do more applications in the right superior vein? That's what you were saying?
Yes. Okay.
Okay.
Yeah, I think. Yeah.
I mean, I think it is a.
No, go ahead, Julian, please.
No, I think we wanted to approximately will state similar things. What we tend to do, we are more liberal to give more applications these days as to the initial recipe.
True.
And we also did and do dare to give a little smaller configuration than the basket. We call it the olive. And we also believe that a little more distal, and this is what we learned also from Advent and other studies, that the risk for PV stenosis is very low. And therefore, I feel much more liberal and less resistant to ablate. A little more, of course, not 20 applications, but 2 more at each vein. This is what we do.
Dale.
I tend to do an extra couple anteriorly on the superior veins, following that the Danish study, which showed that there was an increased redo. You know, in the redo PVIs, they looked at reconnections and saw that there was an increased reconnection rate anteriorly on the superior ones. So I just do a couple with a bit of anterior torque on the superior veins.
Yeah, in this case, we have finished the Now what we are going to move the catheter towards the anterior part of the right superior pulmonary vein, in order to cover this area where the reconnections are observed, these 2 applications in this position, and then we will apply in the carina. We are trying to cover perfectly these areas in which the ablation can be suboptimal or are those areas in which in the review procedures. In our experience, the review procedures, the reconnections has been always in this part of the right superior pulmonary vein, this anterior superior part of the right superior pulmonary vein. Okay, and now let's go to the carina. This is a carina, okay. Okay, move to applications. Yes, we are in flower. 2 applications. Ah. Okay, retira, pull back the sheath, and now finally, puedes sacar. Okay, we are in the right inferior pulmonary vein, and usually what we perform is to start, this is different, which is the workflow recommended. Then we start in the right inferior pulmonary vein in the flower configuration instead of the basket configuration, in order, because for us it's easier to start performing this ablation of this pulmonary vein in the flower configuration, and afterwards using the basket configuration. And then we are going to start with the flower configuration. It's perfectly deployed in the ostium of the right inferior pulmonary vein. Right inferior pulmonary vein has been isolated. Okay, I have turned around, okay? Sí. Okay, and finally, we are going to apply in the basket configuration. Okay, please, can we start? Okay, please. Okay.
Yeah, it is. I was not sure if it's just a Frankfurt problem or is it a general problem. Sometimes we appear to lose some connection, but I think we can clearly see that all veins have been treated, and of course, different configurations have been used. Now we are back live. This is great. So, Joaquin, now you have almost completed treating all PVs, and
yes,
in total, or do you individualize the amount of applications you do more than the proposed 8 recipe based on the patient's individual anatomy? This would be question number 1 for you. And number 2 would be, you also, of course, mentioned and your great experience of REAM or using high-density maps in the context of PFA ablation with the single shot device. And in your, maybe limited, but in your experience with repeat procedures, do you see, how does it look like? Is it exactly the same lesion size? Is there any regression, or what are your experience on that, acute versus chronic? Because you have the unique experience. We don't have this data of looking into all the acute remaps.
Okay, well, I think that 2 questions. The first one, we always, in this moment, we always apply more than the 8 recommended applications per vein in order to cover the carina of pulmonary veins. We always apply in the carina, especially in the right anterior carina, by orientating the far drive sieve towards the carina anteriorly from the right superior pulmonary vein and from the right inferior pulmonary vein. And in the left side, we always try to apply on the left anterior carina, usually just from the left superior pulmonary vein. This is because what we have observed in all the REMAPS procedures that we have performed acutely in our patients. We think that this can probably increase the efficacy of the procedure. We are trying to identify, to observe, because we have several patients with a lot of REMAPs. We are trying to observe if this presence of this perfect coverage of the carina in comparison to those patients with an imperfect coverage of the carina, the follow-up is different in terms of atrial arrhythmia recurrences. This is what we have observed acutely. Our experience chronically is that usually the patients, the recurrence is affects only to one pulmonary vein. And usually the area of reconnection is very limited. This is a very brief area of reconnection, especially in the anterior part, usually in the right superior pulmonary vein. This is what we have observed. We have always tried to identify the posterior area. We have compared in the reduced procedure the area, the limit of the area between the ablated area and the preserved tissue in the acute procedure in comparison with the chronic procedure. And usually, at least in the posterior wall, the level of isolation remains quite stable, reflected that the system probably you should to be more carefully trying to apply this electroporation, especially towards the anterior part of the pulmonary veins.
All right, okay. And I mean, with future generations of technology enhancement, I would say, there may also be the potential one day to have, let's say, a simulation of your lesions placed on your 3D map. And based on your experience, and at least we observed some reentient tachycardia running around the posterior wall. So with your approach, you probably are able to understand that early on, I believe.
Yes. Mm-hmm. Well, it's quite easy to understand that this posterior wall atrial macro-reentient tachycardia after this kind of procedures, because the systems tend to apply towards the posterior wall. And in some cases, we have observed the presence acutely of a posterior corridor of preserved tissue that can be the perfect substrate to maintain posterior wall macro-reentient atrial tachycardia. Well, we observe this problem in the first cases, then we try to avoid this problem. Then in our experience, we don't have a lot of atrial flutter or a lot of left atrial macro-reentient tachycardia. I think that because we observe this problem in the initial cases, then we have tried to avoid this situation. And in this case, we have compared the follow-up data with a cohort of patients treated with radiofrequency, and the percentage of patients that recovers in atrial flutter is similar in comparison to comparisons with the group of patients treated with radiofrequency. But I agree with you, Julian. This is, I think that if you are not aware of this problem, if you not avoid this extra application towards the posterior wall, you are giving the patients the possibility to recover in an atrial tachycardia.
Yeah. And now you have selected PFA as the energy source in this specific case. And I think many people would be interested about your thoughts and also the panel's thought about empirical ablation with PFA of maybe the posterior wall. And how is your experience on this, on your perspective on this? And then maybe we also get to know the panelists' ideas on this empirical ablation on the posterior wall using this technology.
Well, I think that there is a lot of controversy regarding the posterior wall ablation. I think one of the main limitations that in the information that we have is that until now, we have used radiofrequency for posterior wall ablation. Then I think that the radiofrequency is an energy that is suboptimal because you cannot obtain a real posterior wall ablation in some patients acutely. But in the cases in the studies that has evaluated the durability of this posterior wall ablation, the results are really depressing. The percentage of patients in which the posterior wall ablation is maintained during the follow-up is very low. Then we have performed in several patients this posterior wall isolation with this technology. I think that this technology allows you to obtain 100% acute efficacy performing posterior wall ablation. This is the first point. The second point is that you are performing a real posterior wall ablation because, for instance, with radiofrequency, what you are doing is for performing a box in the posterior wall. With this technology, you are eliminating all the activity in the posterior wall. You cannot observe after posterior wall isolation with Farapulse, you cannot observe any single activity in the posterior wall. You cannot pace locally nothing in the posterior wall. Then this is, I think, at the moment, the best tool to perform the posterior wall isolation. If it works, I'm not telling that. I think that we can evaluate the usefulness of this ancillary ablation for atrial fibrillation patients with this technology. And we don't have a lot of data in the follow-up regarding the durability. We have performed just one review patient in which the patient was treated with posterior wall ablation. And in this case, the posterior wall still was isolated in the review procedure. We have data only one patient with a review procedure after posterior wall ablation.
Yeah, thank you. Maybe we now ask from, at least I see it in the list, from top to down, and ask Vivek about your thoughts about the empiric posterior wall ablation.
Yeah, I mean, look, a couple things.
As the energy source.
Yeah. I mean, with the point that Joaquin just made about the difficulty with RF durability on the posterior wall, I 100% agree. My philosophy has changed completely with pulse field ablation in terms of, let's say, ease of creating the posterior wall lesions and my propensity to do so. Now, having said that, I have to say I tend not to ablate the posterior wall, even with pulse field ablation in patients who are paroxysmal. I tend to really focus this on the persistent patients. And even there, I think it's probably going to end up being a subset of the patients who actually benefit from posterior wall ablation. But it's relatively easy to do, and I guess, I tend to do it. The durability data is, we published some time ago in a very small number of patients that we had very good durability. As you may be aware, in the United States, we completed a very large single-arm trial, 400 plus patients with PVI plus posterior wall and persistent patients. We're in follow-up there, and hopefully next year we'll have the data. There's a second very large single-arm trial, also called Advantage Phase 2, where we have the same sort of lesion set plus CTI line, but also with implantable loop recorders in that second group. So I think we'll have a lot of good data, almost 1,000 patients between those two studies in the upcoming years. But right now, in persistent patients, I tend to do it.
Okay, Claire?
Yeah, so I mean, I agree with a lot of things Vivek's saying. I think it's important to kind of understand that we're really asking two questions. So we're asking whether kind of theoretically doing posterior wall isolation is a good thing to do. And then second of all, we're asking, like, is PFA a good way of actually creating posterior wall isolation in a durable fashion? And I guess you need both of those things for actual, for the patient to have a good clinical outcome. You need the posterior wall to be durably isolated, and you need it to be a kind of clinically relevant thing. So you can kind of address those things slightly differently. And I guess if you look at like the Kaplan study, which looked at posterior wall isolation with RF, then yes, it didn't show that that it was of benefit, with all the caveats that we've already described with using RF on the posterior wall. So I certainly think it would be useful to kind of repeat those kinds of studies, but using PFA. And obviously we are, as Vivek has said, collecting quite a lot of clinical data. I think it would also be useful to collect robust remapping data as well, to then answer that question of whether PFA is actually good at isolating the posterior wall in a durable fashion. Because one of sort of my issues with PFA, much as I like the technology, is that it is quite frustrating that you don't get sort of feedback during the case as to what your lesion set is going to be like down the line, because whatever ablation you do, you're pretty much going to lose the signal straight away. So if you isolate the posterior wall, yes, you will always destroy all the signal on the posterior wall pretty much immediately. But what you don't know at the end of the case is whether that is going to be durable or not. So I think having some good remapping data would be good. For my practice, I don't isolate the posterior wall for paroxysmal patients, because I do, I kind of believe that concentrating on the veins is important for paroxysmal patients. For persistent patients, I do often do the posterior wall. And again, I mean, I sort of feel as though I'm not being particularly rigorous in an academic fashion in this way, because I end up doing it because it's quite an easy thing to do, and I think that I can do it fast and safely. But I'm not sure that that's a very good rationale, to do something just because you've got a catheter in your hands that can do it. So in my mind, I would definitely like some more data to make me feel better about that when I'm doing my posterior wall isolations.
Yeah, great. Draj.
Just a couple of points on that, Julian. First of all, is the safety of the procedure. We've been all attempting posterior wall isolation radiofrequency for a long time. And in at least a quarter of the cases, my attempts were thwarted by recurrent esophageal temperature rise. And I would always bail out at that stage, because thinking, no, I don't know whether this what I'm doing is having any advantage, but it certainly has the risk of causing damage. So at least with PFA, that risk of esophageal damage is not there in the equation, which I think is a very, very important thing. The second thing is, how do you define the posterior wall? With radiofrequency, we always used to just create a box lesion set, which meant that the lower limit of your posterior wall was between the two lower veins. And we know that a large proportion of the posterior wall lies between the inferior veins and the coronary sinus. Now, with the pulse field ablation, you can target that area quickly, safely, successfully. So when I use pulse field ablation for posterior wall isolation in patients with long-standing persistent AF or persistent AF, I don't just stop at the inferior margins of the inferior veins, but I take the lesion set all the way down to the roof of the coronary sinus.
Yeah, great. Thank you. There's another, Vivek, you want to comment? Yeah.
Yeah, I want to just comment on this. I guess this is a pet peeve of mine, I suppose. And this is, the point that was made by Claire and others about the fact that electrograms disappear. You don't know if you're really durably isolated or durably ablated or whatever. I think it's an important point. There's no doubt about it. And pulse field certainly makes electrograms disappear quickly. My only point, I guess, is that it's not like this is new, right? I mean, with radiofrequency, we ablated tissue all the time, thought that everything was gone, and it wasn't. In fact, it was even more common, I would argue, with radiofrequency, that we didn't get durability. So I guess that's my only point. It's not that pulse field is unique in its ability to give a false sense of security, let's say.
Yeah, that's a very important point. I also just wanted to add, of course, that just ablating because we can do it is not a very good motivator to do this. Therefore, I fully agree. We definitely need more data and systematic data to better understand. And it's great to learn. There's more data to come. And we will know much more next year. Just another, at least, point, we should also not forget ablating more and more just because it is so easy to do is also something we should keep in mind, because there's recent reports about, for instance, like hemolysis if you overdo it. So therefore, there's something also to keep in mind. And also, of course, vasospasm may occur depending on of course, the location. And there's also something we have to acknowledge, but still, the big promise of PFA, of course, it is safety and its ease and its reproducibility. And therefore, I am very, very curious about the future. There's a lot of more data coming up. And I think by now it is time, because we are running a little bit out of time for this session, to thank our operator, Joaquin, and your team in Spain for doing this great case and so being so flexible, jumping from the one strategy to the other strategy. And we have seen that you did a beautiful case, and congratulations to all of you guys. And of course, I again need to thank my great panel. Excellent comments, great insights from Duraj, Claire, and Vivek. And for all the audience, there's more to come on the second day of Rio. And on the next, we have a symposium. The symposium is entitled Latest RF and Mapping Innovations to Treat Paroxysmal AF. So therefore, stay with us and stay connected. Thank you, guys. It was a wonderful session, wonderful case. And again, congratulations.
Thank you.
Thank you very much.